Hi everyone, this is me, Dr. Tiwari, and again today I am here with a very important topic. Okay, this is about psychiatric emergencies. We'll read about a lot of important topics. I'm sure in every examinations, be it USMLE 1 or 2, PLAB or NCLEX, you will surely get one of the questions, at least one of the questions from this topic in this video. I'll try to make the video concise, but yes, even if you think that the video is long, then you just can you just say increase the speed in YouTube, and then you can look into this. Okay, it's a very important topic. I'll definitely share some of my insights regarding the important questions or important points during the video. So let's move on. So yes, there are lots of let's say there are not lots but a few psychiatric emergencies conditions, and in which rapid recognition and immediate intervention is necessary, and time is the crucial factor in managing these conditions. Otherwise sometimes there may be immediate death too. Okay, so we can categorize the psychiatric emergencies into three different types. One is drug-induced syndromes, like Serotonin Syndrome, Neuroleptic Malignant Syndrome, acute dystonia, lithium toxicity, TCA tricyclic antidepressant toxicity. Similarly, withdrawal states. We have also discussed about different withdrawal states in different other videos, but since it's emergency, so let's talk about alcohol withdrawal here. Okay, Delirium Tremens, alcohol withdrawal, this is a similar thing. And yes, delirium tremens occurs 2 to 4 days after cessation of alcohol. And also drug-to-drug interaction is important, like the famous MAO inhibitors here we are talking about drug and food interaction. Okay, so MAO inhibitors with tyramine rich food, which can lead to hypertensive crisis. So yes, these are the three broad classifications, and under this we will try to learn about psychiatric emergencies. So first, let's learn about serotonin syndrome. So serotonin syndrome is basically a situation in which there will be excessive serotoninergic activity in the central and peripheral nervous system. So if the person is taking some drugs, let's say SSRIs, and if there is another drug added to it, or any other substances like MAO inhibitors, SNRIs, TCAs, vilazodone, bortioxetine, buspirone, this all increases the serotonin activity. So if there is a combination of two or more than two, then this can lead to serotonin syndrome, that is excessive serotonergic activity in central and peripheral nervous system. Okay, and sometimes if these are not used together, but if there is not adequate washout period between two drugs, let's say the person is taking SSRIs, and if the clinician thinks that that SSRIs alone is not enough, and if suddenly the doctor adds another drug without much interval in between, so let's say now the doctor added MAO inhibitor just 2 to 3 days late after SSRIs, after the last dose of SSRI, then there is not adequate washout period. So although the drug is not used simultaneously at the same time, but after 2 to 3 days, that still can lead to serotonin syndrome, because there is not adequate washout period. Okay, so these are important. So as I said, these combinations of psychiatric medications can lead to can lead to serotonin syndrome. And also there are some other non-psychiatric agents. This is very important. So in examinations, sometimes SSRI with tramadol, SSRI with ondansetron, SSRI with triptans, SSRI with linezolid, these are frequently asked questions. Okay, and SSRI with dextromethorphan. So when there is a combination of SSRI and either of these drugs, which are non-psychiatric agents, but you have to know that this increases the serotonin activity, and if the symptoms matches with that of the serotonin syndrome, and then they will ask what's the diagnosis or what is the antidote, and in that case you have to understand, okay, these are the potential drugs which are non-psychiatric in nature, and still can lead to serotonin syndrome. So maybe it's the serotonin syndrome and you just pick up the correct answer. Always remember, SSRIs with tramadol, ondansetron, triptans, linezolid, MDMA, dextromethorphan, this can lead to serotonin syndrome. Senson wards, okay, these are all important. Meperidine, that's another opioid. Now, if the person is getting serotonin syndrome, so there must be some clinical manifestations, right? So the clinical manifestation is 3 A's. We say it by 3 A's. One is, let's say, altered mental status, like the person will be agitated, will be in confusion, may have delirium, anxiety, or in severe cases may progress to coma. And similarly, autonomic instability, that is another important terms. Okay, here the person's vital signs get dysregulated, may have hyperthermia, increased body temperature, tachycardia, increased heart rate, labile blood pressure, diaphoresis, mydriasis, diarrhea, flossing. And the third one is increase in neuromuscular hyperactivity, neuromuscular hyperactivity. So this is very, very important. So when the person is taking 2 drugs, which has potential to increase the serotonin activity, so altered mental status, autonomic instability, okay, and there will be always some hints like clonus. Clonus means rapidly shaking movements of our lower extremities, okay, sometimes ocular also. So says there will be neuromuscular hyperactivity, not rigidity. Rigidity is in neuroleptic malignant syndrome. This is a very crucial differentiating factor. So here the patient will always have clonus or hyperreflexia, hypertonia, tremors, and in severe cases seizures. So these 3 A's is somewhat linked to serotonin syndrome. You have to remember that. That's altered mental status, clonus, or let's say a neuromuscular hyperactivity, and autonomic instability. Now the management of this is discontinue all serotonin agent instantly. So when you immediately, okay, this needs to be done. Then separate treatment can be done, like if there is increase in temperature, you can do active cooling, IV fluids, benzodiazepines for seizures or agitation, okay, vital sign monitoring, this can be. And the specific antidote is cyproheptadine. This is serotonin receptor antagonist. This is very important antidote, and most of the time you can see these questions in the examinations, okay, you have to remember this. And prevention status is avoid concurrent serotonergic medicines, and at the same time allow adequate washout period when switching between 2 serotonin increasing drugs. Especially the washout period is better if there is 2 weeks. But always remember, this is another question important, fluoxetine has a very half-life time, okay, so because of that the washout period must be at least 5 weeks, okay, because fluoxetine has long half-life. So you cannot just wait for 2 weeks before prescribing another drugs after fluoxetine. You have to wait for 5 weeks. This is important. Now next is MAO hypertensive crisis. This is another psychiatric emergencies, okay. This is MAO-I, this is MAO inhibitors, okay. So what happens is that when the person is taking MAO inhibitors, so the MAO inhibitors, the MAO is an enzyme that breaks down norepinephrine, okay, and the norepinephrine is somewhat made from tyramine. Tyramine is also found in different food products, and these are the examples of food products like aged cheese, processed meats, fermented foods, alcoholic beverages, chocolates, okay. So whenever the person takes MAO inhibitors, then this norepinephrine or the tyramine cannot be broken down by the body. So because of that there will be excess of norepinephrine, okay, that in one hand may be important for the therapeutic reason, but if at the same time concurrently the person takes these foods which are high in tyramine, so now even the tyramine cannot be broken down, and the tyramine further converts into norepinephrine, and now there will be excess of norepinephrine, okay. So this tyramine containing food we have to cut down, or let's say we have to avoid during when you are taking the MAO inhibitors drugs. Okay, like salicylic. So while taking those drugs, you have to avoid taking this tyrosine rich food, so that there won't be excessive of norepinephrine activity. And norepinephrine activity, it causes high blood pressure. It's sympathetic mimetic actions. Okay, so here you have to remember tyramine word. And next thing is like cheese, curated meat, salami, pepperoni, kimchi, soy sauce, wine, beer, and chocolate and fava beans. These are the foods that has high tyramine. And the clinical features can be hypertension and severe occipital headache, diaphoresis, palpitation. Okay, so then when the person taking MAO inhibitors say that they had taken these foods and they present with these symptoms, then you immediately think about hypertensive crisis. And the treatment approach is always use phentylamine. Okay, phentylamine is alpha adrenergic blocker, and so you have to use phentylamine, and you have to avoid using beta blockers alone. This is another important question in the examination. So norepinephrine acts on alpha 1, alpha 2, beta 1, beta 2 blockers receptors. Okay, and they increase the adrenergic activity. Now this, especially the alpha activity is high, so the blood pressure is high. Okay, in hypertensive MAO inhibitor induced hypertensive crisis. So in this case, it's better you give phentylamine, which is specific alpha adrenergic blocker. So that's why now the blood pressure falls down. Okay, but if in case of alpha adrenergic blockers like phentylamine, if you give beta blockers alone, then at the time you think that okay, the blood pressure is rising, so may I prescribe beta blockers. So at the time the beta blockers will be working on beta receptors, but the alpha action will just continue. So because of that, there will be very high blood pressure, one thing. And next thing is that beta receptors also sometimes help to balance the effect of alpha mediated blood pressure increase. So if the beta is gone, the alpha action gets much more also. So always use alpha adrenergic blockers, that is phentylamine. Okay, and counsel the patient that you are not to take those foods again when you are taking these MAO inhibitors drugs. Next is Neuroleptic Malignant syndrome. Now in this condition, we have to remember that when you are taking typical antipsychotics, and at that time there is always chances of Neuroleptic Malignant syndrome. It's a life-threatening condition, idiosyncratic condition, and in this condition there will be it's a result from severe dopamine receptor blockade in the nigrostriatal, hypothalamic, and mesolimbic pathway. So as you are using antipsychotics, so there will be decreased dopamine activity, and when this is to excess, sometimes to a person specific, then this leads to Neuroleptic Malignant syndrome, and it is life-threatening, and it often occurs 1 to 3 days after medication. Okay, but it can occur anytime, but still much more common after 1 to 3 days to those person who will experience NMS, that's Neuroleptic Malignant syndrome. And its clinical symptoms is easy to remember. Just remember the word fever. So yes, it has high grade hyperthermia, that is the fever rises up to 104 degree Fahrenheit and 40 degrees Celsius. This is important clue in examinations. Okay, and E for encephalopathy, the person has altered consciousness ranging from confusion to coma. B is for vital unstable, so there will be tachycardia, level blood pressure, tachypnea, fast breathing, diaphoresis. E is for enzymes elevated, so here there will be creatinine kinase increase from up to let's say greater than 1000 international unit per liter, and this can be linked to myoglobinuria as well. So the person will have rhabdomyolysis. This rhabdomyolysis, because of that, the creatinine kinase gets increased, and also you see the dark urine and sometimes acute kidney injury. This all under this letter E over here. And the last is rigidity. Lead pipe rigidity is seen in neuroleptic Malignant syndrome. So the clinical features, you remember by the acronym fever. F itself stands for fever, E stands for encephalopathy, B stands for vitals unstable, E stands for elevated enzyme, but that especially CK greater than 1000 units per liter, but that also you have to remember that is because of myoglobinuria or rhabdomyolysis, which can also present with kidney failure or dark urine. And last R stands for rigidity, that is lead pipe rigidity. The management of NMS includes discontinue antipsychotic immediately, and you have to use dantrolene because there is muscle rigidity, so you have to use dantrolene. Dantrolene works on ryanodine receptors, and the calcium mediated contraction is decreased because of that, and hence the muscle relaxant effect. Similarly, bromocriptine and or amantadine, these are dopamine agonists, and yes, since the dopamine level is decreased in case of NMS syndrome, so now we try to boost up the dopamine action, so we give bromocriptine or amantadine. Similarly, benzodiazepines for sedation or muscle relaxation, and this is also a very important aggressive supportive care, that is IV hydration, active cooling, and ICU monitoring. Okay, you have to monitor creatine level, renal function, electrolyte very closely, and also since whenever electrolyte is involved, we always do cardiac monitoring. Now next is delirium tremens. We have read this in different heading also, different video also, but still I like to talk about it here. So delirium tremens represent the most severe form of alcohol withdrawal syndrome, typically 2 to 4 days after the last drink. And more, this is important, this is not for exam, but just a general knowledge. So 5 to 15% of the population, okay, who undergoes cessation of alcohol may land up in delirium tremens. Okay, or let's say whenever there will be more delirium tremens, I think this is better to frame like this: whenever the person has delirium tremens, at that time almost 5 to 15% of the person may die. Okay, so in the psychiatric ward, when especially in substance abuse unit, when the person is kept over there for alcohol withdrawal syndromes, and then either voluntary or let's say involuntary, and at that time he or she may develop delirium tremens, and at that time we have to counsel the patient party that 5 to 15% there is always mortality risk. And clinical manifestation, again, the patient will have confusion, disorientation, and hallucination. Visual hallucination is most more common. Okay, don't confuse with tactile or auditory. Visual hallucination, tactile is most more common with cocaine, auditory in schizophrenia. So visual hallucinations in alcohol, and autonomic hyperactivity. So there will be fever, tachycardia, hypertension, diaphoresis. So this may lead to death. Okay, so and there is tremor, and yes, the management includes benzodiazepines, so chlordiazepoxide and diazepam. We have to give these drugs for the patient with on alcohol withdrawal. And always remember, this question has been, I think, is very important. If the person who is on alcohol withdrawal also had already developed liver failure or hepatitis, because there is chance, right? Because the person who is a chronic alcoholics have liver cirrhosis or let's say hepatitis, and in that case instead of giving this chlordiazepoxide and diazepam, which are metabolized by the liver, we go with these drugs, lorazepam, oxazepam, or tenazepam, any of these drugs. But the better is tenazepam is not used properly, but lorazepam and oxazepam, I think these are good drugs for the liver failure patients in case of alcohol withdrawal. This lorazepam is very important to remember. Okay, are safer in liver failure patients. And yes, as I said earlier in different video, thiamine should be given before glucose administration, and electrolytes will be always monitored, especially magnesium, potassium, and phosphate. Now next is acute dystonia. Okay, in acute dystonia, its mechanism is sudden sustained muscle contraction, due to dopamine blockade, typically within hours to days of antipsychotic or antiemetic use. So here, if the person is taking antipsychotics and then like haloperidol, and then another, people remember this antipsychotic is related with acute, but you have to remember antiemetic like metoclopramide and prochlorperazine, especially metoclopramide. Okay, this drug also can cause acute dystonia by blocking the dopamine action, and this can occur within hours or days of taking these drugs, either antipsychotic or antiemetic like metoclopramide and prochlorperazine. And yes, in this case there will be muscle contraction, like you can have oculogyric crisis, forced upward eye, deviation, torticollis, neck twisting, opisthotonus, arched back, and laryngospasm. So when there is a laryngospasm, airway emergency needs to be planned, and immediate intubation may be needed also. So hence, because of this, we put this under emergency, okay, psychotic emergency. And the treatment is benztropine or diphenhydramine. And when you give diphenhydramine, there will be dramatic relief in 15 to 30 minutes. But however, you may need to repeat the dose again, but there is some improvement definitely with diphenhydramine and benztropine. So this is important, okay. Acute dystonia, you give acute dystonia occurs when the person is taking antipsychotic and also some antiemetics like metoclopramide and prochlorperazine, and in this case there will be sustained muscle contraction, oculogyric crisis, laryngospasm, torticollis, opisthotonus, and in this case you keep benztropine or diphenhydramine. This is important, okay, diphenhydramine and benztropine, this is frequently asked. And also this metoclopramide, this is also important. Now, lithium toxicity. We all know that lithium is used in bipolar patients in case of mania, for maintenance and everything, but yes, this lithium can also present the patient in case of bring the patient in psychiatric emergency, okay. Like sometimes the patient, lithium has very narrow therapeutic window, so when the person may land up with some of the symptoms like let's say if the range of lithium in the blood is increased than 1.5 to 2.5, up to 1.5 to 2.5, then there will be mild clinical presentation like nausea, vomiting, fine tremor, diarrhea, muscle weakness. If it's more than 2.5 to 3 but less than 3.5, then there may be confusion, ataxia, dysarthria, and hyperreflexia. But if there is severe, like greater than 3.5, then the person can land up with seizures, coma, cardiovascular collapse, nephrogenic diabetes insipidus. This is also another important, okay, frequently asked. So and pulmonary neurological damage. So lithium, whenever the blood level is greater than 1.5, you can always think about the person having bipolar disease, mania. In that case, if the person has been prescribed with lithium, and if the blood level shows greater than 1.5, and if there is either of the symptoms like nausea, vomiting, let's say dysarthria, or let's say hyperreflexia, coma, cardiovascular coma, seizures, anything like this, kidney failure, anything like this, then you can think of lithium toxicity. Okay, and lithium toxicity is risk increases if there is renal impairment in the person, okay, because lithium is cleared from the kidney, and if the kidney is impaired, then the lithium level increases in the blood, and hence the toxicity. And similarly, if the person is taking NSAIDs, ACE inhibitors, thiazide, loop diuretics, these all work on the kidney, okay, so kidney or renovascular system. So yes, because of this also, when these drugs have been taken concurrently, then there is the chance of lithium toxicity. When there is volume depletion, the person is dehydrated, vomiting, diarrhea. If the person was mania, who was given lithium, but the person developed a few days before, the person developed vomiting and diarrhea, or was dehydrated, and then suddenly the person may start developing these clinical features, and then you have to think about, okay, that may be because of lithium toxicity. Okay, and then when there is lithium toxicity, first thing you do is discontinue lithium immediately, okay, and check serum lithium level every 4 to 6 hours. You need aggressive hydration provide IV isotonic saline, normal saline, to maintain the urine output, enhance renal lithium clearance through the urine. But again, since diuretics can lead to decreased kidney function, so it's better you avoid diuretics here. And if IV saline is alone not adequate, or discontinuing lithium is alone not adequate, then in this case we may have to move to hemodialysis also, especially when the lithium level is greater than 4 MEq per liter. Or if the person has developed renal failure. Hemodialysis rapidly clears the lithium. And always in this case also you monitor ECG, because lithium can prolong QT interval, so you monitor ECG, check renal functions, electrolytes and everything. And if the person has seizures, then benzodiazepines can be used. Now we'll talk about tricyclic antidepressants. So we have to remember that tricyclic antidepressants, we frequently use SSRIs, SNRIs, in bupropion, these drugs in case of depression patient. But we used to use tricyclic antidepressant, and we all know that these have lots of side effects. Why do they have a lot of side effects? Is that they act on multiple receptors. So the desired effect for treatment of depression is because they act on norepinephrine and serotonin, so we use that for depression. But they also have worked on alpha receptor, muscarinic receptor, histamine receptor, also sodium channel. They block the sodium channel. They block these receptors, alpha muscarinic and histamine receptors, and has some effect on potassium channels. And all these are the culprits for side effects of and TCAs, like amitriptyline, nortriptyline. So the classic toxicity is convulsion. So the person may develop seizures, result from GABA antagonism, sodium channel blockade, in the CNS. Similarly, may develop coma. Coma is because of severe antihistamine and anticholinergic effect, or let's say antimuscarinic effect. And cardiotoxicity because of ventricular arrhythmias, white QRS, hypertension from sodium channel blockade. So since there is cardiotoxicity, since there is convulsion, coma, so we always think that TCA is a potential drug which can lead to psychiatric emergencies. Clinical features, additional clinical features, then these 3 C's, convulsion, coma and cardiotoxicity, are mydriasis, dry mucous membrane, urinary retention, hypothermia, altered mental status. Similarly, QT prolongation, as I said, and also hypertension because of peripheral vasodilation. And in case of TCA, we always remember this sodium bicarbonate. This question is frequently asked in the examination. So the antidote is sodium bicarbonate. It reverses cardiotoxicity by increasing sodium gradient. We know the cardiotoxicity is because of the blockade of sodium receptors, sodium channel blockers. So hence we give sodium bicarbonate because this increases sodium gradient and reverses cardiotoxicity, and hence the person will not collapse, right? And additionally, we can give activated charcoal if the person has taken excess of TCA within 1 hour of ingestion. If he comes into the hospital, then we can give activated charcoal too. And benzodiazepines is always there for seizures, and we avoid class 1A and 1C antiarrhythmic drugs because they worsen sodium blockade. Now key clinical pearls or takeaways is that all the recognition of the psychiatric emergency is very important. Otherwise we may lose the patient, because you see these drugs or these conditions affect the heart, cause seizure, and sometimes the person may collapse, right? And next thing is let's remember this way: there are 3 A's for serotonin syndrome, that is hyperactivity, autonomic instability, and altered mental status. And NMS, Neuroleptic Malignant syndrome, can be remembered by remembering the acronym fever, where fever, elevated enzymes due to rhabdomyolysis, vital instability, encephalopathy, and rigidity will be there. Heat pipe rigidity, we said, that is important too. And TCA toxicity, we say 3 C's: that is convulsion, coma, and cardiac toxicity. And always these antidotes, these are important. I'm talking this from examination point of view also. Okay, so sodium bicarbonate for TCAs, dantrolene for neuroleptic Malignant syndrome, phentylamine for MAO inhibitor crisis, benztropine for acute dystonia, cyproheptadine for serotonin syndrome, and hemodialysis for lithium. Okay, I think with this we complete this video. This is a very, very important topic in psychiatric condition. You often see a lot of questions from this. Okay, so I hope this video is helpful to you. You can always revise this video quickly on the 2 speed or by increasing the speed in YouTube. And yes, now after this, if you try to solve the questions, I hope you'll be able to solve maximum questions from psychiatric emergencies, these topics. I strongly recommend that you revise this topic again and again, and I hope you will do better in the examinations. Please don't forget to like, share, and subscribe. And also I recommend you to save this video or share with your colleagues too, okay, so that you both can do or better in the examinations. And if you have any suggestions for me, please comment down in the comment section. See you in another video, another interesting video. Bye, take care.